Nowadays, as interventional cardiology gets more aggressive, we see more and more of complex cases, be it bifurcation lesions, be it ostial lesions, be it left main lesions, be it chronic total occlusions or tortuous lesions, calcific lesions. So on an average, I deal with close to 15 or 20 bifurcations every month, of which most of them, almost 70%, are treated by a provisional strategy and 25 to 30% are treated by a dedicated bifurcation strategy. Well, challenging side branch access is one of the most important critical determinant of success of a bifurcation angioplasty, and in my personal opinion, at least 15% to 20% cases offer significant challenge for access, be it an acute angle or substantial tortuosity or calcification just exactly at the carina, which makes bifurcation angioplasty that much difficult. For side branch protection, I typically keep a wire in the side branch so that the access remains open. Having a wire in place makes my access to the side branch easier in case if I need to recross through the main vessel stent. Sometimes I might need to put a balloon also. Sometimes if it is too difficult, I might even preemptively dilate a side branch ostium if I feel it is necessary, and sometimes even doing a proximal optimization of the main vessel stent can help access to the side branch easier. The biggest challenges in side branch expansion happen to be the angulation between the main vessel and the side branch, the angle of carina. If there is substantial calcification at the side branch ostium, that offers another substantial challenge, and the takeoff of the side branch, whether it is acute, obtuse or perpendicular. So these are the different, sometimes it also happens to have a Shepherd Crookes origin, so that offers even more challenge, and in such cases we sometimes use an angulated microcatheter for gaining access to the side branch ostium. Well, incomplete lesion expansion or stent expansion is not that common, because if I go for a provisional stenting or elective bifurcation stenting, then I make sure that the side branch lesion is well prepared. I pre-dilate very aggressively using non-compliant balloons before I go for stents. So I make sure that the lesion bed is well prepared, any substantial residual fibrosis or lesion is aggressively treated, and only then I put the stent. Stent is not primarily used for lesion expansion, it is only used to deploy the stent in place. Well, I would say it is a fairly important parameter for success in a bifurcation angioplasty, because most often we encounter that the side branch comes at an acute angle or at a very, very difficult angle where passing a stent becomes a little difficult. If we happen to use any guide extension catheters or other maneuvers like a balloon assisted tracking, then sometimes we end up distorting the stent struts if the struts are not good enough. So yes, having a very good trackable, flexible strut metal will make side branch access easier. For good side branch expansion or in bifurcation angioplasty in general, I would choose any stent which has an open cell design. So open cell design makes the stents are also very well trackable. Secondly, recrossing through one layer or two layers of struts is that much easier. So I would prefer to choose stents which have an open cell design over a closed cell design. Well, in the past I have used a couple of times dedicated bifurcation stents, but most of the times, 99% of the cases, I use the regular stents. The choice of stents are different, but yes, I do use the regular stents only most of the times, and I'm able to do it quite comfortably. It is very important that important determinants of success of a bifurcation angioplasty are: on table you have to have good carina coverage, there should not be any ostial miss, the overlap of the side branch stent struts in the main vessel should be minimum, The neocarina should be very well developed. There should be complete adequate coverage of all the lesions. Proper optimal optimization is very, very important. There should be, of course, TIMI3 flow without any residual lesions or any substantial dissections. And in the long term, the patient's MACE risk happens to be the most important clinical determinant for any bifurcation angioplasty. The side branch ostium is actually the most common site for MACE. The most common site for restenosis in a bifurcation angioplasty, whether it is left main or non-left main bifurcations, is usually almost always the side branch ostium. So how adequately it is prepared, how adequately it is treated and stented is a very important determinant of success, both short term as well as long term. Absolutely. If there is a stent designed specifically designed to save the side branch ostium, it will save a lot of adrenaline for the performer, and it will reduce the MACE risk a lot in the long run for the patient also. So I would be very excited and will be very open to adopting any such new cell design. If there is any prospective randomized control trial comparing conventional stents and a dedicated bifurcation stents, and that data shows a better MACE risk, I would be very happy to adopt such a stent design for my bifurcation cases.